morning, everyone. I am Dr. Abhishek, Assistant Professor in CTBA, Mehta, BGMC. Today we will going to discuss about the Ebstein Anomaly. And we divide our topic in the following heading: embryology, epidemiology, classification, clinical features and pathophysiology, investigation in which we see the ECG, echo and X-ray of the Ebstein anomaly, and we will then plan about surgery, and then we also do anesthetics management and what after intraoperatively we do the post-op care. So starting from the embryology, as we know, during cardiac embryogenesis, expansion in the size of the right ventricular inflow tracts like that elsewhere in the ventricle occurs by the process called as the undermining. It is important because this is a point where we have to focus again on next slide. Subendocardial portion of the ventricular free wall become fenestrated and spongy as resorption of the myocardium progressively dissolve the wall, thereby enlarges the chamber size. Concomitant growth along the subepicardial region maintain or increase the ventricular wall thickness as the heart enlarge. In these slides, we are seeing that this is portion toward the RA side and that is toward the RB side, and this is the endocardial cushion. We see this endocardial cushion will elongate and proliferate, and this ventricular wall is become spongy and fenestrated. That later it become more spongy, and that fenestration also increases in size, and but endocardial cushion, or you can say start proliferating and form a fibrous sheath. It is later function as a atrioventricular wall. It is a normal process, and if we discuss about the Ebstein anomaly, here the spongy myocardium is not good, and there is a failure of the undermining. It is called as delamination, failure of delamination, in which this portion is remain adhered with the myocardial wall. Later it become atrialized. It is also called as atrialized or right ventricle, and from here this is a true annulus, and now here the leaflet act as a wall. Leaflet act from this point of view, we can say it is a false annulus, or you can say functional annulus, and this portion is atrialized RV. Ebstein anomaly in embryology, as we discussed in the diagram, failure of the delamination of the septal and the posterior leaflet of the tricuspid wall. Septal and the posterior leaflet is important, and we see the downward displacement of these leaflets, and there is also a marked development of the myocardial wall and the valvular component. There is the anterior and the apical rotation of the functional orifice in the Ebstein embryology. Now then we will go introduction of the Ebstein anomaly. It is actually malformation of the tricuspid wall and the right ventricular characterized by adherence of the septal and the posterior leaflet, downward displacement of the functional annulus, in which septal is more displaced as compared to posterior and the anterior. There is a dilation of the atrialized portion of the right ventricular with various degree of hypertrophy and thinning of the wall. Redundancy, fenestration and tethering of the anterior leaflet, and there is also dilation of the right atrioventricular junction. It is true tricuspid annulus. Normally we know in human heart, downward displacement of the septal and the posterior leaflet in the relation to the anterior mitral wall is leaflet is approximate less than 8 mm per meter square body surface area, but this is a very important point, less than 8 mm per meter square body surface area. If it is more than that, it is a characteristic of the Ebstein anomaly. In this diagram we will see the downward displacement of the functional annulus. Here normally the annulus is here, it is called as true annulus. This leaflet remains attached with this myocardium, and there is a failure of delamination. From here this leaflet remains, then it acts as a functional annulus. That portion is the atrialized RV, and FRV means functional RV. These also decrease the RV cavity, so later also hamper the pulmonary blood flow, and that RV, atelized RV, become dilated and hypertrophied. This is characteristically also seen in the X-ray, ECG, and also in the echo. On the basis of functional RV and atelized RV, we will plan surgically. Later, this diagram shows normally what happened, the anterior mitral leaflet and the tricuspid septal leaflet is distance between them is approximate less than 8 mm per meter square, or you can say normally more 10 mm per meter square, 10 mm. But if this distance is become increased, or you can say it is more than 10 mm, it is called as Ebstein anomaly. It is measured in the CT or echocardiography. Now, history and epidemiology. Wilhelm Ebstein initially described the characteristic tricuspid valve abnormality in the autopsy specimen in 1866 in 19-year-old cyanotic man. See, here historically they describe in the 19-year-old cyanotic man, but we know Ebstein anomaly is a disease, which abnormality is a congenital heart disease in which you can find a wide range of patients from in utero to the old age. It account approximate less than 1% of the congenital cardiac disease and present in 1 in 20,000 live birth. Morphology of the Ebstein anomaly include the malformation and the displacement of the tricuspid valve leaflet toward the apex of the right ventricle. Now we classify this Ebstein anomaly on the basis of the qualitative and the quantitative characteristics. So classification is qualitative is given by the Carpentier and the quantitative by the Celemazer, or you can also call it as a Gauss system. Carpentier classifies in 4 types, type A, B, C, and D, depending upon the true RV volume. Similarly, Celemazer discoding system, Gauss system, in which they take the area of the right atrium and the atelized right ventricle, which is divided by the functional right ventricle and the left ventricle and the left atrium. On the basis of this, they graded into 4 parts. Grade 1 is if that area sum is or you can say that division is less than 0.5, it is called as grade 1 and it is have good prognosis, and if it is more than 1.5, it is a poor prognosis. Here in type D we also see there is a complete atelization of the right ventricle, means RV is nothing, functional RV is not there. So prognosis is very poor in the grade 4, or you can say it in type D. As we know, hemodynamics of the Ebstein anomaly depend upon the severity of the RVOTO, pulmonary stenosis, and the degree of the atelized right ventricle, and also RV dysfunction. If there is a severe pulmonary stenosis or the pulmonary atresia present at the birth, then what happens? The pulmonary blood flow is not adequate. Then it is filled by retrograde filling of the branch PA from the patent ductus arteriosus. Despite of the absence of the prograde flow across the pulmonary wall, there can be a pulmonary regurgitation in the functional pulmonary atresia. So that can also lead to circulation physiology if there is a severe tricuspid regurgitation, in which we see the LV push blood to the aorta, and from aorta it goes into the PDA into the MPA, and from MPA via pulmonary regurgitation it comes into the RV, and from RV via tricuspid regurgitation is coming to the right atrium, and from right atrium via ASG into the LA, and from LA to LV. So it is the circulation physiology seen in the Ebstein anomaly. See this diagram, from LA to LV, then from LV to aorta, and from aorta via PDA to the pulmonary artery, then PR comes into the RV cavity via tricuspid regurgitation to the RA, and then to the via ASD to the LA. It is very characteristic of Ebstein, and also it causes rapid deterioration in the utero or neonatally and carries a very guarded outcome. Later, Apical displacement of the tricuspid wall creates an atrialized portion of the right ventricle. Then it is the atrialized portion of the right ventricle. So this portion have ventricular morphology but functionally serve as a part of atrium. This area of the RV later thins and dilates over time, eventually become the aneurysmal with paradoxical motion. Malformation of the right ventricle cavity ranges from the clinically insignificant to the severe hyperplasia depending upon the degree of valvular displacement. So this RV cavity and their size also determine our surgical plan. On the basis of severe end of the disease spectrum, inadequate blood flow through the pulmonary wall in utero result in the functional or the less commonly anatomic pulmonary atresia or stenosis. There is a abnormalities in addition to the tricuspid regurgitation result in the diminished RV outflow. So the majority of the patient have the atrial level shunting either in atrial septal defect or the patent foramen ovale patent foramen ovale. Left ventricular function may be compromised due to the right ventricular distension and resultant bowing of the interventricular septum into the LV cavity. So bowing of the interventricular septum into the LV cavity also decrease the LV output or LV cardiac output. In coronary arteries, there is also abnormalities because RCA is going through the backside of the true annulus. Here, coronary arteries are normal except the right coronary artery. It may be displaced superiorly or posteriorly because the aneurysmal dilation of the atrialized right ventricle. So therefore, surgeon should carefully follow the course of RCA during the operation. It demarcate the level of the true annulus and maybe become kinked during the plication annuloplasty procedure of the or tricuspid valve replacement. So during surgery we plicate the atrialized portion of the right ventricle, and during plication that RCA may damage. So we should keep this point in our mind while doing the surgery. Now we discuss, depending upon the hemodynamics, we have clinical features and its pathophysiology. So if patient present in the neonates or in the later childhood stage, the symptoms are different. So we see if patient comes in the early stage like in neonates, then it is a very severe form of the Ebstein anomaly, and if they come in the later stage, it means patient is stable, RV volume is good, they are maintaining till that age. It means they can have a little bit good prognosis. So the patient with the tricuspid severe malformation, hypoplastic RV or the RV outflow tract obstruction are symptomatic shortly after birth, and patient come with the cyanosis because RV is a hypoplastic, means the RV is not able to push the blood into the pulmonary blood flow. Since pulmonary blood flow is decrease, it means the cyanosis is very common. SP2 is not maintaining. And if they come in the later infancy, it means patient have the moderate tricuspid valve malformation and no associated RVOTO. And if it is a mildest form, then they comes later in the childhood, more later, even in the adult. So first we will discuss about the neonates. In neonates we are focusing, then we can diagnose the Ebstein anomaly via ultrasound in the mid gestation, even the child was not born. Severely affected fetus often develop hydrops fetalis and pulmonary hypoplasia, and 20% cases die in utero. Neonates who present with a circulatory shock or profound cyanosis represent a subgroup of patients with the severe disease and increased morbidity and the mortality. Severe tricuspid malformation results in the TR, RV hypoplasia, and a variable degree of the RVOTO until pulmonary vascular resistance fall over the first few days of the life. Egress from the RV and can be extremely limited, with physiology resembling that pulmonary atresia. There is a right to left stent across the septum and left to right stent across the PDA are necessary for LVP load and pulmonary blood flow respectively. Further, there is a paradoxical motion of the ventricular septum into the LV which may impair the LV filling and also decrease the cardiac output. If the patient with the pulmonary insufficiency follow through the PDA, it can result in the circular shunt of the blood from the aorta to the PA into the RV and back through the ASD to the systemic circulation, further compromising the cardiac output. And if there is a severe cardiomegaly, then what happens? Lung will not expand very well because thoracic cavity is a closed cavity. Lung expansion hamper, it means there is a compromised pulmonary function. But in most cases, lungs are not truly hypoplastic. They are good, but still due to the very last cardiomegaly, they are not expanded. But they can be expanded after normalizing the cardiac size, or we can say after the surgical correction of the cardiac disease. Remarkably, as many as half of the neonates improve dramatically as the PVR falls and are able to avoid a surgical repair in the early infancy. So later, now we are discuss about the older infant and the children and the adult patient. So these patients are the past their neonates time. It means they have a mildest or the moderate form of the abnormality of you can say normal Ebstein anomaly, or you can say moderate abnormality of Ebstein anomaly. Here we discuss patient with the mild disease of the valvular displacement and the RV hyperplasia are relatively asymptomatic in the early infancy and present in the childhood, adolescence, or even in the adult, with symptom of the attributable to TR as right failure or the arrhythmia. Older children have the markedly better outcome, and we see death in this patient may be due to the arrhythmia, paradoxical embolus, cerebral abscess, or later right side heart failure. There is a large atria is enlarged till that age due to the apical valve displacement, and the TR creates a substrate for the atrial fibrillation and the flutter. Structural abnormalities of the tricuspid annulus and periannular tissue contribute to development of the accessory conduction pathway, and multiple pathways are often present. In older patient, decline in the functional status, persistent arrhythmia, increasing cardiomegaly, or worsening of the RV dilation with declining systole function may prompt surgical intervention. Surgical intervention typically preferred in NYHA class 3 or 4th. Then we go for the pre-op evaluation and the management. In pre-op evaluation for the neonates, we mostly focus on the optimizing the forward pulmonary and systemic blood flow. We support the ventricle. We maintain the adequate ventilation. Neonates with severe Ebstein anomaly have the pan-systolic murmur at the left cisternal border because of TR, and cardiomegaly is present in the chest X-ray, and ECG shows what right bundle branch block, or you can say first degree AV block, or you can say there is a conduction abnormality because of the displacement of the true annulus, and sometimes there is a breach in the annular pad. Diagnosis is confirmed by the echo. Now, transthoracic echo should be used to evaluate the tricuspid valve anatomy, function, degree of TR, presence of the atrial shunting, and the biventricular size and function. RVOT should be assessed for functional or the anatomic pulmonary atresia. Septal leaflet displacement from the true annulus index to body surface area greater than 8 mm per meter square is a sensitive predictor of the Ebstein anomaly. This point is very important, more than 8 mm per meter square for the Ebstein anomaly. Cyanotic patients should be started on the prostaglandin infusion before diagnosis diagnosis to ensure the adequate pulmonary blood flow. And those with significant acidosis and hypoxemia requires intubation and sedation and paralysis. So if there is a severe RVOTO and the restrictive atrial septum defect, then what we do, we open this atrial septum by doing the balloon atrial septostomy, and we maintain the ventilative parameter to minimize the pulmonary vascular resistance. We have also used a nitric oxide. We also use a high FiO2 to avoid the hypoxemia and hypercarbia. Anatomic support is required to improve the cardiac output to the RV and the LV both. And most neonates improve clinically as PVR decreases over a period of few weeks. Patients who do not have significant RV failure or hypoxemia after ductal closure can eventually be discharged with close follow-up to determine the need for surgical intervention. Those with persistent symptomatic RV failure secondary to the TR or this RV dysfunction requires early tricuspid valve repair. We will see this whole theory in a flow chart, which is shown. We first, when the patient comes to our side, we have to start with the prostaglandin infusion, inotropes, and do the ventilatory management. If we give the prostaglandin infusion and assess the TR, RV function, and the RVOTO. If the symptomatic patient was improving and improved, later we didn't need any intervention because PVR will fall over few weeks. And if there is a hypoxemia is present without right and left heart failure, then we can do BT shunt or we do the PDA stenting. And if there is a persistent symptomatics or there is a right or left heart failure, then we see there is RV hypoplasia is present or not. If RV hypoplasia is severe, then we do RV exclusion or BT shunt. And if it is not, then we attempt for the tricuspid valve repair. And this is the flow chart if we are going to manage the neonates. Secondly, in older infants and the children, we also have a flow chart to manage these patients, but we will see what we find clinically in this patient. We will find the poor feeding, dyspnea, cyanosis, and the growth failure. And we also find there is the exercise intolerance, fatigue, palpitation, and the syncope. And if we do physically examination, then we find there is a hepatomegaly, cyanosis, and the abnormal heart sounds. There is also a frank JBP because of the TR. We also see found in the wide splitting S1 during auscultation because of the large anterior tricuspid valve leaflet. And we also find there is a pansystolic murmur of the tricuspid regurgitation in the neonates period. We also find cardiomegaly in the X-ray. We also find ECG. We see the ECG. We find the supraventricular arrhythmia such as atrial fibrillation, flutter may be present. Cardiac catheterization is unnecessary unless there is a patency of the coronary circulation. Patient with the history of the arrhythmia, we have to go for the electrophysiologic evaluation and intervention prior to the surgical correction, because surgery itself can lead arrhythmia. So we have to know previously what is going pre-op and then what we do intra-op and then how to manage post-operatively. This is a whole chart to manage the older patient. Because patient cross their neonatal period and the patient comes with the symptom, means this Ebstein anomaly is mild in its mild form or in the moderate form. If patient is symptomatic or RV failure or arrhythmia is there, then if present, if not present, then it will only observe, we do nothing. If arrhythmia failure or severe RV failure is there, then we see if there is only arrhythmia, then we do Holter monitoring, do EP studies, and if that is a symptom, that is a cause of symptom, then we have to manage this. Then we have to manage the arrhythmia. And then if we manage the arrhythmia and also see the RV condition, if it is in failure and symptom is due to the RV, then what we do? We do the tricuspid valve repair or replacement or bicuspid pulmonary anastomosis. And what is not, by RV dysfunction is not present, then we can attend with the tricuspid valve repair or replacement. So depending upon the RV function, we decide we can go with the repair or replacement or BCPA, or you can say 1.5 ventricle repair. RV dysfunction, or you can say RV function, or you can say RV value is the main point who is going to define us. Either we go for the univentricular repair or I'm going for the biventricular repair depending upon the RV value. So if we are planning a surgical plan for this patient, then we have to see if there is an abnormal tricuspid valve. This is a true annulus and this is a false tricuspid valve annulus. It is the abnormal tricuspid valve, then we have to repair this. There is a decreased pulmonary blood flow because of the very decreased RV cavity. So we have to increase the pulmonary blood flow via doing PD stenting, or you can say BT stent, or we can say the BDG. If there is a right ventricular size is very less, then it helps to provide information about the univentricular or the biventricular repair. And if there is a ASD and PD is present, we have to close it. And if there is a supraventricular arrhythmia, we have to manage preoperatively, and we can also manage this supraventricular arrhythmia in the habit OT. We can do some maze procedure if there is a arrhythmia along with the surgery. Surgical approaches are, we see depending upon this plan, our surgical approach is already defined. Either we go for the tricuspid valve repair if RV size is good and person is adequate and support the two ventricular circulation. And there are several palliative operations like ductal stenting, balloon atrial septostomy, aortic pulmonary shunt, right ventricular exclusion, or also called a stance procedure, or the complete repair. If there is RV function is small, or you can say that the impaired RV function and low PVR is there, then we can manage with the patient with the 1.5 ventricle repair. We'll discuss the whole this in the slides. For tricuspid valve repair, there is a many procedure where you can, on the basis of that, you can repair the tricuspid valve. Like Daniel and the Foster, they create a monocusp valve using an enlarged anterior leaflet. Then Carpenter and the Kuberg's modification, they also detach the anterior and the posterior tricuspid leaflet and repositioned, rotated at the level of the two tricuspid annulus. Lastly, and the most accepted is the cones reconstruction devised by the Da Silva. They have a more anatomic repair approach with a multi-leaflet wall at the level of the true tricuspid annulus. We will see this procedure in diagram, then we can understand very better. What happened in this? They do anterior leaflet is mobilized from the annulus, leaving the caudal attachment intact. Similarly, the annular attachment of the posterior and the septal leaflets are surgically dissected away from the RV wall. The posterior leaflet is rotated clockwise and joined to the septal leaflet, and the wall is reattached to the level of the two annulus with plication of the annulus to match the size of the reconstructed wall. So here we see the diagram of the cones repair. See, in first diagram it is a functional annulus, but true annulus is here. That portion between this is called as atrialized right ventricle. So we have to plicate this. We have to mobilize these all leaflets and attach with the true tricuspid valve annulus. So here we are mobilizing the all leaflets. It is the anterior leaflet, and we also mobilize the septal and the posterior leaflet. And then what we do, we plicate the right ventricle and we do annuloplasty and tricuspid wall repair, and this and attach the all leaflets margin to the true annulus. We have to know this is a 10 o'clock position, 10 to 12 o'clock position where the membrane septum is present, and here there is a conduction pathway is going on. So less suture we have to apply over this during the repair. We have to keep it this point in our mind. So the how beautifully the cones form in this post-operatively. It is also called as cones repair. See, all the leaflets are sutured together. We will see, and this at least always plicated. We will see better in our next slide, in the next slide or in the last. Tricuspid valve replacement. In adult, we go for the prosthetic valve or the mechanical tricuspid valve replacement. If entire tricuspid leaflet does not permit the adequate reconstruction, and we have it is given that the suboptimal hemodynamics results and needs for the multiple reoperation in the children with prosthetic valve replacement is reserved as a last resort in the pediatric patient. So similarly, the right ventricular exclusion, here when we see there is a tricuspid valve anatomy and the RV function is unfavorable for the biventricular repair, then we go for the univentricular repair. And attempted tricuspid failure is failed to restore the adequate hemodynamics, then we go for the RV exclusion, or you can say stance procedure. Here the tricuspid valve is patched with autologous pericardium and is fenestrated to facilitate decompression of the RV, which continues to receive blood from the Thebesian vein. A generous atrial septostomy creates a common atrium and allows the systemic venous blood to reach the left ventricle. And we also do a modified BT shunt. And patient with undergoes a neonatal stance procedure typically continue down the single ventricle pathway with a bidirectional cave pulmonary anastomosis, you can say BDG, followed by the Fontan procedure. And transplant is also an option. Here is a diagram showing the stance procedure. Here is the tricuspid valve annulus, and we patch with autologous pericardium, and a 4 mm or 5 mm hole is created in this patch to decompress the right ventricle. Atrial septostomy is done to divert the blood flow, and from here we also do to increase the pulmonary blood flow, we do a BT shunt to improve the pulmonary blood flow and decrease the symptom of the patient. 1.5 ventricular repair means only BDG. We divert the SVC to the pulmonary artery to increase the pulmonary blood flow. It is the additional palliative operation for the patient older than a few months old with low PVR, and RV function is inadequate to support the biventricular circulation. This is the only important point. Then we go for the 1.5 ventricular repair. Like in this patient, we will see it is a normal heart, and this is Ebstein anomaly. Atelized RV cavity is very small. To increase the pulmonary blood flow, patient has a symptom of the cyanosis, and RV cavity is, you can say, moderately deformed. It can take the blood from the IVC, but unable to take the blood coming from the SVC and IVC both. It's later, so that patient becomes symptomatic of due to the RV failure or RV volume overload. So what we do, we divert the one side of the blood. We divert the SVC into the pulmonary artery, and still the IVC from IVC blood is going via the same pathway. It is called as half ventricle repair. So half blood of the right side is diverted directly into the PA. But condition is required, we have low PVR to for the good flow, so that good flow goes across the SVC to the pulmonary artery. So it's the same theory here. One point is important for one and half ventricle repair. LVEDP should be less than 15. Mean PA is less than 18 to 20 mm of Hg, and transpulmonary gradient is less than 10 mm of Hg. And what half ventricle repair does, it reduces the RV preload and decrease the RV work by diverting the SVC flow into the pulmonary artery, while the RV continues to receive inferior vena cava flow and contribute the pulsatility flow into the pulmonary vasculature. So here via flow chart we will see if we do a tricuspid valve repair or replacement or RV plication, and there is an adequate tricuspid valve and the RV function is present. If present, then it is okay. If not, then what we do, we significantly TR is present despite best attempt, so we do tricuspid valve replacement. Here the RV function is adequate. But if significant TR despite best attempt at repair with RV is also failed here, then we do for the BDG plus minus tricuspid valve replacement or repair, or it is also called as half and half ventricle repair. If there is a adequate hemodynamics without evidence of the RV dysfunction, then it is okay. Otherwise, we can leave the PFO to decompress the RV. Then now we know about the surgical plan, then we have to know about the investigation and how we manage intraoperatively, because during surgery they are going to change the anatomy of the heart. So we have know previously what they are planning. Then accordingly we go for the investigations and decide a plan for the pre-op management and also the intra-op management and then also post-op management. So in echo we see how much the RV is present, how much at least RA is there, RV is there, what is the size of the RA and LA and LV. We also calculate the quantitatively what is the prognosis of this patient in this, what is the function of the tricuspid valve and the RV, and what is the condition of the pulmonary valve and size of the MPA, and if there is an additional shunt is there, then we have to know ASD is present, PDA is present or not. So in echo, what is our goal? We have to see the apical displacement to define the Ebstein anomaly. It should be more than 8 mm per meter square. We see the tricuspid valve morphology, function, fenestration, or there is a multiple orifice, or there is shortened chordae or underdeveloped. We define it by a Z score. Z score means how much that tricuspid valve is standardly deviated from the normal age and the height of that group of the patient. Then assess the tricuspid valve regurgitation by the color and the spectral Doppler. See, this diagram shows very well. It is atrialized right ventricular, septal leaflet, and this is a functional right ventricular. In echo, this is a functional right ventricular, atrialized right ventricular. Septal displacement from the AML to the septum is more than 8 mm per meter square in this body surface area, and this is the RA. We measure the whole size, and if we want to calculate the goose via the goose system, we also guard the prognosis of this patient. Next, we also see there is a tricuspid stenosis also for the pulmonary stenosis and pulmonary valve, hyperplasia, and the size of the MPA and the branch PA. Also see the pulmonary artery cells present or not, and additional where there is a PFO, ASD or PDA is present, then we have to know. Lastly, assess for the circular shunt physiology requires presence of the severe TR, PFO, ASD, PDA or pulmonary regurgitation. We also see the RV function and the size via the tie index or the fractional area change. And we also see there is a geometric distortion of the right and the left ventricle present or not, because geometric distortion also make the quantification of the functional challenging. The quantification of the function of the right and the left ventricle is challenging. last slide for the echo is we have to calculate the chamber area ratio via the area of the RA and the at last right ventricle divided by the area of the right ventricular plus LA plus LV. If it is more than 1.5, here is written as 1, it is more than 1.5 in the neonates indicates a very poor prognosis. So see, in this echo we calculate this RA plus area of the at last right ventricular divided by this area. It is more than 1, it is have the poor prognosis. 1.5 is a more poor prognosis. This is toward the poor prognosis. So this is a video showing there is a floppy AML and the septal leaf is attached, and distance between this is very large. And second, here the distance in here is very large, is more than 8 mm. Severe TR is present via the tricuspid wall annulus. It is approximately 2.8. RA is very large and RV is very large. Means this patient have the good amount of the RV, so we can go for the tricuspid wall repair or replacement. This is the adult patient. Now after echo we confirm our diagnosis. We see the, if we see the X-ray, then what we find, there is a huge cardiomegaly. Huge cardiomegaly means due to the at least dilation of the RA and the RV. Sometimes you can say due to this cardiomegaly, the lungs are not expanded very well, but they are not hypoplastic mostly. If we correct this cardiomegaly or plication, then they are very well expanded. Also, we see a characteristic seen in the X-ray. It is called as a box-shaped abnormality in the Ebstein anomaly. Due to, see this diagram, here is a box-shaped abnormality in the Ebstein anomaly. It is formed due to the narrow pedicle. Since the pulmonary trunk is not a border and cardiomegaly is present, cardiocity ratio is more than 0.65 and dismissed pulmonary vascular margin in this patient. It is more than 0.5, it is cardiomegaly. Next, in ECG, what we see is this portion is atrialized. The annulus is displaced. So from this point we have to know this portion of the atrialized right ventricle creates a fragmentation, or you can say it fragment the cuboides. So fragmentation of the cuboides complex is characteristic of the Ebstein anomaly. Second, there is a displacement of the annulus from here. So the annular pad is present between this atria and the ventricular is breached. So you can see some accessory pathway in this anomaly. So more than 5 to 30% of the patient, you can see there is an accessory pathway which can show the Wolff-Parkinson's like ECG in strips. And you can also see the right atrial hypertrophy or enlargement in the ECG. So this is the main points we have to consider in the ECG. Due to the right atrial enlargement, we see the tall and the broad P waves or complete or incomplete RBB. There is a AV node is compressed as a central fibrous body abnormally formed, and the right bundle branch may be abnormal or show a marked fibrosis. 6 to 36% of the patient have the more than one accessory pathway, and it is located around the orifice of the malformed tricuspid wall. AF and the atrial flutter are most likely because of the secondary alteration of the right atrial myocardium from previous cardiac surgery and post-op as a result of the incisional atrial tachycardia. This disease shows the QRS fragmentation in this patient. In CT and MRI, it is for the functional anatomy of the patient and their anatomical details. If we do the cine MRI, then we also, it is like akin to the echocardiography. We can know the everything about the how much that lies the right ventricle, how much the TR is there, And if there is a other abnormality like ASD, VSD, and then we have to know in the CT and CT MRI. And this MRI if we are doing, then we have to quote our true RV value. How much the true RV value is present. Depending upon this, we decide our surgery. Now, last part is anesthetics management. So, intraoperatively, first we discuss about the neonates and then we discuss about the adult. If we see the neonates are the critically ill because patient if comes in early stage means Ebstein anomaly is severe. If they are critically ill, then we have to mechanically ventilate and maintain on inotropic support, prostaglandin infusion and the inhaled nitric oxide prior to surgery. And in this type of patient, milrinone is the choice for the inotropic support as it improves the RV function with minimizing the pulmonary vascular resistance. Intraoperatively anesthesia is maintained with the combined of volatile anesthesia, opiates and the muscle relaxant. Intravenous IV line should be carefully inspected to avoid the infusion of the any air leading to the paradoxical embolus. And NIRS to also provide information regarding the perfusion. We also use the antifibrinolytic such as tranexamic acid is the class 1 indication to decrease the blood loss and the transfusion requirement. Electrolyte should be corrected. Ventilation and the oxygen should be adjusted to avoid the increased PVR, and the PEEP should be set at the minimum necessary to prevent the atelectasis, given the deleterious effect of the excessive PEEP on the RV afterload and the tricuspid valve regurgitation. After tricuspid valve repair, neonates will initially require the inotropic support and aggressively RV afterload reduction to successfully separate from the cardiopulmonary bypass. So we have to start milrinone intraoperatively after coming the cardiopulmonary bypass. We load with the milrinone either with 0.5 or 0.75 mics per kg per minute for 10 minutes, and then we continue the maintenance dose of 0.5 mics per kg per minute. Then T is allow the assessment of the degree and the mechanism of the residual TR, and it is helpful in the evaluating the biventricular function and the intercardiac air. T is important in intraoperatively. ECG is must be carefully monitored for the evidence of the any impairment in form of rhythm. Like if we damage the right coronary artery during the surgery, then it may lead to atrial or the ventricular arrhythmia, AV blocks. So we have to focus on ECG also intraoperatively after coming the bypass. If there is an adequate tricuspid valve repair is not possible, then we go for the RV exclusion. In older infant or children or in adults, we present with the tricuspid valve repair for the tricuspid valve repair. So it means they passes the neonatal period successfully. It means they are placed electively for the cardiac surgery. Then we give the oral pre-medications. ECG in 20% of patients shows supraventricular arrhythmia. So we have to know about these conditions preoperatively. Inhalational induction can be safely performed in the most children and carefully considered for the ventilation and the RV function. There are several case reports of delayed intravenous induction attributed to anesthetics agent pooling in the large RA. Thus, careful dosing and the patient are required to avoid the excessive dose of anesthetics. Large RA may be serve as a reservoir for the delayed release of the medication, resulting in the prolonged duration of the action of the anesthetics agent. Here, PA catheter is challenging because severe TR is there. Thermodilation is not reliable because of the setting of the TR. T is very important for the confirming the anatomy of the tricuspid valve, mechanism of the tricuspid regurgitation, and the assessing biventricular function. Pulmonary vascular resistance should be minimized, and so we can use a nitric oxide. We also provide support to the RV function. Patient with the inadequate RV function to support a full cardiac output, then candidates that are the candidate for the 1.5 ventricular repair. These patients should be managed similarly to other patients undergoing a BDG procedure or bicable pulmonary anastomosis procedure. Then lastly, postoperatively we will see initially focus on the RV afterload reduction. Then because the large and the fibrotic RV often ill-equipped to deal with the hemodynamic changes. So maximizing the RV output is essential. We give the appropriate sedation and the analgesia, and later if the function is improved in the echo, then we slowly wean our support. Later, if the patient is severely affected, then we have to require several days of ventilatory and the inotropic support. Later, according to the echo guidance, and we will decrease our support, wean the ventilator, and extubate the patient in the post-op period. Carefully monitoring is required for the arrhythmia. Patient with the junction rhythm or intermittent AV block in the immediate post-operative period typically regain the sinus rhythm with normal AV connection after the first 2 days. Perioperatively ventricular arrhythmia appear to increase the risk of late sudden cardiac death, and some authors recommend the prophylactic antiarrhythmic medication preoperatively and also in the post-op period. One suggested regimen include the intravenous lidocaine in the immediately post-op period and the oral procainamide for the first several months post-operatively. But it is a choice. You can use. If everything is okay, you can avoid it. The potentially poor arrhythmic effect of these agents should be carefully considered prior to the prophylactic use of any antiarrhythmic. Lastly, we see some pictures about the cone repair, how beautifully it is seen. We mobilize all the leaflet and attach to the two annulus, and later it seems a cone-like shape and placation of the RV. Next diagram which shows better. It is a atelized RV. It is a two annulus, and here is the functional functional annulus, and it is a functional RV. From here we mobilize all leaflet. We delaminate. There is a failure of delamination. We cut these all. Mobilize the leaflet, and like this here we cut all leaflets. Now we placate this atelized right ventricular, and then these mobilized leaflets attached to the two annulus and making it is a cone shape. It is called as cone repair. And intraoperatively
यहाँ देखिए आपको सिर बहुत नीचे आएगा, फिर इमेज में फिर ऐसा ही आएगा.
Okay, intraoperatively we see this diagram. Here this is a suture line between the leaflet anterior and the septal leaflet, and this is the posterior leaflet. See, if you see lastly, this is the septal leaflet and this is the posterior leaflet, and it is the anterior tricuspid wall leaflet. It is mobilized, sutured, and attached to the true annulus, and it form a beautiful cone shape intraoperatively. And if we see the postoperatively in the echocardiography, we will see this is a cone shape structure formed, and postoperatively we decrease the tricuspid wall size, decrease the TR, and increase and maintain RV output. If we see what happened with the atelized RV in post, if after coming the bypass, and if in post of TE, if it is akinetic, some leave that part, but if it is dyskinetic, means then we have to resect that part, and because due to the dyskinetic movement of the atelized RV, later it form the aneurysm. Some surgeon what they do with the atelized RV, they placate it. After placation, what happened? There is a myocardium fold form. So some studies shown that if that is a focus, that fold are the focus for the arrhythmia, and sometimes the sudden cardiac death is seen in this patient, and there is a ventricular arrhythmia. So depending upon you can say there is a you can say there is a many guidelines which shows, or you can say from starting this atelized RV, what what we do with the atlas RB in the post-op period. In the post-op, after having the bypass, if we see if there is a akinesia or akinetic movement, we can leave. If it is dyskinetic, it means there is a chance of the formation of the aneurysm. And if we can do plication of this RB as we normally do, but we remember this plication create the myocardium fold, and there is a chance for the arrhythmia, and notice also focus for the arrhythmia. And some surgeon, it is a research area, they put some stem cell in that area for the growth, and they may change the RB morphology or the RB ball function, and but it is a research area. So that's all from my side. Ebstein anomaly, hope you will understand very well. Thank you so much.